All right, so here we are, having finished all of the steps in the immune response except for one. And that is that when the immune response has done its job and has taken care of whatever invader it was or whatever injury needed to be dealt with, it then needs to return back down to its baseline homeostatic level, because it would be inefficient and wasteful, and in some cases potentially injurious if activated cells continued to be activated after the invader was gone. So very quickly now, let's refresh our memories on exactly what we have done so far, because you've been with me for several hours at least now, and we've been talking about those stages of the immune response that started with the penetration of some sort of barrier system, followed by the inflammatory response, then the cleanup of the initial acute inflammatory response involved that communication with sentinel cells, so-called, that would both clean up the debris and would communicate downstream in the engineering design to the next cell of the adaptive immune response. So that was my APCs, my antigen-presenting cells, like my mononuclear phagocytes and my dendritic cells, who would then communicate to my immunological general, who I refer to as my T helper cell. And that cell was then induced to undergo a differentiation into one of two categories of T helper, one that controlled the cell-mediated immune response, one that controlled humoral, and then send signals downstream to activate the effector cells that actually did the job of clearing up the mess. So keep in mind that we just finished those two chapters speaking about cell-mediated immunity first and then antibody-mediated immunity. And so we hope that one or the two of those, or both of them working conjunctly, manage to get rid of that invader and take care of the problem. So at this point, the cells that have been activated will express memory of having done that before. Not only do I have a much larger number of them then, because intrinsic in all of this, in the adaptive immune response, is the aspect of cloning oneself in order to make copies of responding cells. So now, as we need to reset this response for the future, realize that it's fairly simply done in the context of the humoral immune response because of the fact that there is a very short lifespan of the plasma cell, which is the effector on that side of the immune response. Those cells live only 2 weeks. They spend all of that time being factories for antibody, pumping out antibodies as hard and as fast as they can, and at the end of that time they die. So unless I make more plasma cells from the dividing pool of B lymphocytes, that immune response will wane, or at least the production of that antibody will wane. Now, we spoke early on about the lifespan of a mature, naive B lymphocyte being a day or two, but the B lymphocyte memory cell lasts about 10 years. So I would say that humoral memory has about a 10-year lifespan, okay? In the case of cell-mediated immunity, of course, my issue is that those cells are actually much more long-lived. And so, although it used to be said that these cells would last a lifetime, now that we know that human beings last longer than they used to, we have certainly increased life expectancy to well beyond what that would have been anticipated in the caveman era. But the problem is that we really were not designed to last as long as we currently last. So what we need to consider is that as we increase the lifespan of the human, it's going to be necessary to reinstill cell-mediated immunity at about a 40-year repetition cycle. That's probably about how long our early ancestors were designed to last. Now, something else to consider within the T cell compartment is that T cells do their job by creating cytokines. And cytokines are communication molecules which generally have the result of turning on or turning off another cell. So it would not be wise for us to continue to turn on these activating or inhibitory cytokines when they are no longer needed. And so Mother Nature has designed something somewhat more aggressive about diminishing the number of activated T cells after the process is done. Activation-induced cell death is accomplished through the trimerization of two molecules on the surface of your T cells. When T cells activate, they express both Fas and Fas ligand molecules. And in some population of cells, those will trimerize at activation, and that trimerization will start the cascade toward apoptosis when they are no longer needed. So they will shut themselves down and actually induce apoptosis in themselves, autoapoptosis, after the response is no longer needed. Now, realize that the signals that are left behind after an immune response will tell the body to strategically plan for a new entry of that pathogen. And so there are tissue signals that cause the dissemination of memory cells toward those barriers that would be most efficient for preventing the disease in the future. I hope it stands to reason to you that something that entered my body through my skin yesterday is not likely to enter through my mouth tomorrow. So if I can specialize my response for the tissue location where it's best used, this is going to be important in the future. And I'm sure that each and every one of you knew this intuitively. Remember that when we vaccinate a patient against something like the tetanus toxoid, we are not going to have to instruct them as they leave the office that they should be certain to always step on rusty nails in the future with their left deltoid. So realize that your body takes into communication with itself exactly where it needs to send the troops to wait there for the future. Okay, now we'll talk about that in our vaccination chapter coming up, because it's true that in many cases we have those types of immune responses that we can elicit on one mucosal surface and then anticipate having it work on another as well. So we will use that as we talk about strategies for vaccination. Now, the anamnestic or memory responses is going to be larger and faster with every institution of the same antigen or immunogen. And this is because each additional inoculation involves the production of more cells by cloning. So when I think about how this looks in a graphic format, realize that if I begin by adding a antigen at time 0, it's going to take me about 2 weeks for me to go through all of the material that we've done before in these discussions, about 10 days to 2 weeks to make a primary immune response to that antigen. And that's because of everything we've talked about. It's actually taken us several hours, I think, to work through the process, just discussing it. Well, remember, each of the steps requires cell communication and turning on transcription factors and making cytokines and having cells respond and perhaps move to an appropriate area. So it almost always takes about that length of time before I have enough of an immune response that I can say that my patient would be protected from seeing that again. Now, what we were just speaking about was the return back to homeostasis. that when this is no longer needed, I will return back toward baseline in any immune response, but I never truly return back the whole way toward the baseline because of the fact that I have more cells, hopefully quiescent now and waiting to see this again, but I still have more cells than I did the first time that are capable of responding to this particular challenge. Now, if I follow that initial administration with the administration of another set of molecules, one a repetition of the first one, but a second being something that the body has not seen before, realize that these responses are independent of one another. Because each cell is making a response that depends upon the shape of its individual receptor, realize that what this means is that my primary immune response to the thing that I've never seen before is going to happen pretty much concurrently with a secondary immune response to what I'm seeing again. And notice that the secondary immune response to my first antigen is very much higher and faster. It does not require a lag time as the 10-day to 2-week period we saw with the primary inoculation. So it's true, if you think about this, that if one allows one's body to do what it is designed to do, to interact with foreign substances, make responses, and then go back to a quiescent state, you can quite quickly reach a point in your life where you have enough memory cells to handle virtually anything that you will see on any given day. And you have to remember that because the populations of cells making these responses are each independent of one another, the primary response to one antigen has no effect on the secondary response to another. These are different populations of cells. They may well be in different locations responding differently. And so it's only when two adult consenting cells bind together in that 3-signal type setup that we end up getting an immune response that's functional to protect the patient. So now let's talk a little bit about why understanding this chapter was important. Going back to my hashtag Make Me Care philosophy here of making immunology relevant to a physician. First of all, an extremely rare genetic mutation in the FAST gene has been shown to cause Canal-Smith syndrome. Can you anticipate the clinical picture of a patient with such a deficiency? It's time now to pause your video, think your way through this, and then when you're done, come back and listen to my interpretation of the answer to that question. All right, so if the FAS gene trimerization is what causes activation-induced cell death, then in the absence of that particular molecule or the ability to trimerize two of those on the surface of my activated T cells, I am going to end up with a syndrome that involves wild lymphoproliferation. At the end of a given immune response, I'm going to continue to have proliferation of the responding cells. And so I would anticipate that I would see these patients with massive enlargements of their secondary lymphoid organs, splenomegaly to the point of rupture perhaps, and lymphadenopathy in any of the typical regions where my body meets antigen every day. Now, I've included in the notes a case study for this lymphoproliferative syndrome, and I'll let you on your own time look at that and see how it is that it progresses and what we do for management. But activation-induced cell death is terribly important for returning things to the baseline, and in the inability to do that, I simultaneously will have too much response to things that I've already vanquished and too little ability to turn on a response to something that might be trying to kill me today. MMC number 2. Given what you know about the lifespans of memory B and T lymphocytes, can you predict the intervals at which booster vaccinations will need to be administered for protective immunity if the necessary response is A, humoral, or B, cell-mediated? Stop your video, think this through, and come back when you're ready. All right, so if you recall, the lifespan of the plasma cell is 2 weeks. That's just the effector. But the B cells who create plasma cells have about a 10-year lifespan. So you can anticipate as we move into our next chapter on practical applications of the immune response that for things where I'm trying to get my patient to create an antibody immune response, and the classic one would be the diphtheria, tetanus, and acellular pertussis vaccine, those are all toxoid material, and I'm trying to make the person make an antitoxin antibody. So I have to repeat those vaccinations with boosters every 10 years to make a new crop of memory cells that will protect the patient. In the case of cell-mediated immune response, it is a much longer issue because my memory T cells, if you recall, are said to last a lifetime. But my classic example here is the difference between the initial vaccination against chickenpox versus the booster that the elderly receive for shingles. Okay, same virus. It is a vaccine that creates cell-mediated immunity. And so, as you would anticipate, I'm probably going to need a booster vaccination as my patient gets into the elderly age group. So the current recommendation is that at the age of 60 or so, persons should have a booster vaccination against the virus to prevent the reactivational disease. Okay? MMC3. Can you explain why the route of vaccination, oral, intramuscular, etc., would have a role in its efficacy? Stop your video and think about this for a minute. All right. Well, remember that my body receives signals from the tissue that tells it where the immune response needs to be located. This allows me to get immune cells into the area where I need them, and it also tells me where to send memory if I have had an immune response that has occurred in a secondary lymphoid organ. So as we age, it's true that our memory cells tend to home to locations that are barrier systems of the body, to the skin and the submucosa, and wait there for a pathogen to enter again. So if I give something orally, I am going to create immunologic memory on the gastrointestinal submucosal surfaces. If I inoculate something intramuscularly, my draining nodes that drain that area, typically the non-dominant deltoid, so it's typically going to be at the axillary lymph nodes. In those cases, I would pump the product out into the blood. But it tends to be true that if I can design a preventive mechanism artificially, a vaccine, that I can administer in the same way that the pathogen is actually going to enter the body, that I can have a much more effective vaccine developed. And in the next chapter, we'll talk specifically about the difference between the Sabin, which is orally administered polio vaccine, and the Salk, which is the killed intramuscular vaccine. And we'll also talk about the difference between the injected influenza vaccine versus the intranasal. Our final question: can you explain to a recalcitrant anti-vaxxer parent why the administration of 3 immunogens in one vaccine, like the measles, mumps, and rubella, does not overwhelm their child's immune response? And trust me, this #MakeMeCare is one you are going to deal with virtually every day in practice because of the large and growing, sadly, population of people who believe that vaccination is something that endangers their health. I'll let you think about that for a while because this is going to be useful to you as a physician. All right, so remember, as I showed you the diagram of how the immune response works, it's important to remember that it is individual populations of cells responding to something based upon the fact that they have a receptor on their surface that fits the 3-dimensional shape and structure of something very unique. The cells that respond to measles in the MMR are different in population from the cells that respond to mumps in the MMR, and different again from the cells that respond to rubella. 3 different viruses turn on 3 entirely different populations of cells. And because your body has evolved to make responses to literally thousands of things in your environment every single day, there is no hope of overwhelming your child's immune response simply with 3 things. If you have any doubt of that and you've ever seen a young child beginning to crawl, you will probably remember that every single crawl they make on the floor, they're licking something. They are putting literally thousands of things into their mouth every minute of every day. And the most aggressive and amazing parent will never in a million years manage to cleanse the environment so that they cannot do so. We are designed to make responses against every bit of our environment all of the time. And so it is simply a fallacy to think that 3 relatively simple, small creatures could overwhelm the immune response. So here we are again at the end of a chapter. As usual, I'm not going to read these points to you. But what I want you to do with these in your spare time when you're done reviewing this material is make certain that you could explain each of these points to a colleague. You really know the material when you're capable of going through it and explaining it to someone else. Use your own words, use your own analogies, but make certain that you can explain this so that it will stay in your mind and be useful to you as we continue.